I've been working with Dawn for perhaps 15 minutes now. And what we did was we equalized rotation in her hips. This right hip extended only about 10 degrees, and now that extends as freely as the left side does. We then created an anterior glide force through the left ischium and pube, because they're fused together. And that appears to have restored the anterior glide in the pubic structure. And we also restored mobility in ribs 1 and 2 on the right side. And I'm going to show you the sacrospinous ligament, which I find right here. I can now indent it, and I can impart stress through it. The pelvis looks different. The posterior iliac shelf, which is my nomenclature, it's not normative anatomical nomenclature, but there is a little shelf here that's rather flat. I could balance a pencil on that, and it is in the middle between the outside of the pelvis and midline of the spine, so you have one on each side. And it's a very convenient landmark for palpation, and there's research on that that validates such. So you'll recall that we could induce movement through the structure on the left, and on the right I can now take up the slack. And then there is force transmission. I see her head bob up and down. So we have improved mobility there, and in terms of posterior to anterior force transmission through that ischium, take up the slack, and I can see her foot move. The force travels through that structure, so it's no longer blocked. And we typically name the anatomical part that we're doing the test on, acknowledging that that's just a bony landmark, and that the force dissipates in a different manner throughout other structures. So we were not able to take up the slack going inferiorly here, and now we can, and the force transmission is very normative. I can see that heel bounce up and down. Okay? So I feel like we've made some progress, and I'm curious to see if this alters the sitting posture. So if you would please sit up and face away from me, and I'll just block the camera a little bit while you're changing position. And I apologize if I get in the way. Sometimes I'm filming and I'm blocking the camera and I'm talking. You can see, pardon me, you can see all the redness here from the work that I did. And it's my belief that these structures will achieve better, more lasting gain when the mobilization is done for a prolonged period of time. Some of these mobilizations I do take 5 minutes with the fulcrum. Some of them are 2 minutes. It just varies. But in sitting, previously, you had some prominence in the interscapular area, the lower part, and I'm just not seeing that as pronounced. The tone in the lumbar spine is quite symmetrical. So there is greater symmetry throughout. Would you bend forward, please? Good. There still is some greater prominence in the right in this area, in spite of having improved rib mobility. And when we come right down to the lower interscapular area, I start to feel that prominence on that side. And previously it was much lower than that, if I recall correctly, and certainly can perceive that greater tone here. So the dynamics have changed. The goal is to find out what is normative for this person, what is changeable, what is not changeable. That is precisely what we're going after. And I suspect that she may have some mild scoliosis in her spine, or she may have some asymmetry that she always will have. And we might have a little bit more information when we're finished today screening her in multiple contexts. And I do need to look at her sitting in a chair and see how the length of the femur and length of the tibia interact, see how see if the trochanters lie symmetrically, pelvis lies symmetrically, or sits symmetrically. But it's an ongoing process, but I'm pleased with the gains that we've made thus far, and I'll stop filming right here.